All right, so good morning from New York and good afternoon to all the APVIC members and participants and the faculty. I really thank giving this opportunity, and I was involved just a couple of years ago with this now the 12th episode of your annual meeting, which is so successful. And when you had called me, I felt that this will be a good way to present my analysis, which I created to see what happens in this clearly pandemic era of the COVID-19, which at present has really taken a different part in terms of many places gone down like New York, and I know India is on the other side at present. So we also knew that while hospitals were flooded with the COVID-19 patients, the cardiac patients having MI and emergency room visits and the ambulances coming to the hospital significantly declined. So that really interested me, and I really put this together, plummeting incidence of acute cardiovascular illness and STEMI during COVID-19 surge. So question basically was that are they truly reduced because of the benefit of change practices and behavior of COVID-19 containment strategy, or unreported or underreported as a subset is dying or having MI at home, patients not coming to ER and hospitals due to fear of contracting COVID-19. So these are the two very important questions which we noted in last few months, 3-4 months, and I'll take you through. And you actually, I would say that I don't have a perfect answer, but I'll try to explain what we are, the reason behind what we are seeing. One, so what I'm going to do is I rapidly go through this, my 15-18 minutes presentation on 4 topics. One is the reported incidence of STEMI during COVID era. Second, the respiratory illness paradox. Third, possible explanation for the reduction. And lastly, future perspective, that what we learn, what we should be doing in this COVID pandemic, which will continue to some extent. So first one is there a true reduction? So first report came actually from United States by 11 centers that 911 activation has significantly reduced from STEMI, and of course there were multiple reports globally, and this basically led to see that there used to be 24.8 visits per site per month, went down to 15 various centers. So 38% reduction of STEMI activation took place. So it was true, less patients being called. Then we have another report from Los Angeles, Kaiser Permanente, and showing that with the increasing COVID-19 patients, there has been a reduction in acute MI. So this is in a brown line, it's 2019. During this time, the last 3 months, and now in 2020 in the black line, as you can see, there is a 38% reduction in patients with acute myocardial infarction. They're both STEMI and non-STEMI. Then we actually have another report from Italy, which showing the similar pattern, the number of daily admissions, which used to be 18 to 19 in the last year, 18 earlier part of the year, now became 13, 30% reduction, and it was both STEMI as well as non-STEMI, 24 to anywhere 50% reduction. The last, I would say, in this field, very extensive data published in European Heart Journal is showing another center from the Italy, almost 50% reduction in MI, 26.5 in STEMI, 65% in non-STEMI. So clearly the phenomena is true that less acute MI patients are at present going down. And of course, there is a report from India, I think it's in the process of publication. They've noted also similar pattern, about 50% reduction in STEMI patients in various centers. Now, as you can see, this is the data at Sinai. We used to have about 27 non-STEMI. We used to have about 60 non-STEMI and 10 STEMI per month, which number has gone down to 27 and 2. Really, again, 60 to 80% reduction of non-STEMI and STEMI. This actually part was the story in our New York Times, because we got a lot of patients who came late also, and that just I'll go through the region, that what are the reasons for these patients who go missing. So first point, yes, true incidence has decreased. Second, we heard the respiratory illness paradox. That is, that it has been shown that anytime you have respiratory infection season like influenza and many others, that there is an increased incidence of myocardial infarction during that time. So respiratory illness goes hand in hand by increased admission of myocardial infarction for patients. This is a study from Canada that during the time of the influenza season, 1 to 3 days, 4 to 7 days, there is 6 to 7 times higher incidence of patients being admitted with MI. So clearly, the patients with more MI occur during respiratory season, and there are clear-cut explanation for it, that people who are predisposed, particularly coronary artery disease patients, patients with a risk factor, diabetes, high cholesterol, that clearly the plaque rupture takes place, which is the type 1 MI, but also many of them have type 2 MI because of increased oxygen demand with tachycardia, fever, increased heart rate, and so. So clearly that there is a relationship between respiratory illness and MI. But what we saw paradox here is that we don't, why COVID-19 being a respiratory illness, that we did not see increase in incidence, rather we saw significant decline. So that leads to the most important point, and that is that there has been a decline in acute coronary syndrome, particularly STEMI, in this time, and I put it into 4 parts. One is the marked reduction in air pollution and nitrogen oxide, decreased vehicular traffic, decreased airlines, decreased factory exhaust. This is all related to what has been done as a COVID containment of implementation strategies. Second, the reduced chemical and gustatory triggers of cardiovascular disease, because nobody going to restaurants. Third, overall relaxed lifestyle and improved mental and physical health and better medical compliance in various ways. I'll point the touch on that. And the lastly, which is very important, that is underreported, as a subset of patients are having ACS and STEMI and are dying at home due to potential for COVID exposure. So let's take one by one. Clearly, everybody agrees that there has been a significant decline in air pollution. Recent papers came in European Heart Journal also to really emphasizing the importance of decreased air pollution and maybe linked to decreased cardiovascular illness. These are various pictures from various parts of the countries. And this is the India gate, and look at the India gate before and after now. Clearly, the pollution has significantly declined. This is well-known phenomena, clearly documented. And we also know that from the Global Burden of Disease Consortium, lot of deaths, cancer and respiratory illnesses occur because of pollution. There is a very nice state-of-the-art paper on this air pollution and cardiovascular disease by Sanjay Rajgopalan, one of our earlier faculty from Sinai. Excellent, really put it together that what is the relationship of air pollution to the cardiovascular mortality. And as you can see here, air pollution really contribute to very high incidence of cardiovascular illnesses. And the relationship has been put into these 3 zones that is well characterized: emerging evidence, zone 2, and zone 3 is inadequate evidence, require further research. So clearly that well characterized is the all-cause mortality and cardiovascular mortality, then your risk factor, hypertension, diabetes, MIs, and so, and lastly, thromboembolic disease, which may be related to increased air pollution. And of the various air pollutants, the particulate matter 2.5 has really correlated with increased incidence of cardiovascular disease after exposure. Now, according to WHO, there has been a standards put about the pollution number, what we should have. And as you can see in Southeast Asia, India, Bangladesh, Pakistan, we have very unhealthy atmosphere because of very high concentration of PM 2.5 beyond, which is the healthy supposed to be considered about 5. And so clearly we fall into that category, but at the same time, higher the exposure of the PM 2.5, higher is the risk of cardiovascular disease. And it is kind of a linear relationship, and also with the ozone exposure and mortality, and same thing goes to the nitrogen oxide. So harmful effect of air pollution are triggered by reactive oxygen species generation in the lungs, with consequent activation of pro-inflammatory signaling such as CRP, IL-6, IL-8, TNF, the hypercoagulable state of the blood, endothelial cell dysfunction, and the plaque rupture. So all of them contribute to a rapid change in our cardiovascular milieu and coming with acute coronary syndrome, or reduction in pollution going other way, benefiting it. And these are very nice central illustration that how basically the pollution gives rise to this plaque rupture and acute coronary events. So now question also comes that what had happened Because of this, our house containment and travel restriction policies, which are obvious, COVID-19 significant reduction in air pollution and nitrogen oxide has cleared our sky, and in turn lead to dramatic reduction in the plaque rupture and STEMIs in such a short period of time. Because this is the most important, that why we saw things within weeks of getting the COVID-19 pandemic. It's because of one of this is the important factor. Now, second comes is the chemical and gestative triggers of cardiovascular disease. We all know numerous studies have shown that consumption of fast food lead to substantial endothelial dysfunction that acutely impairs vasodilatory function, assessed often as reduced brachial artery flow mediated dilatation. And this actually leads to essentially triglyceride, lead to mitochondrial oxidation of free fatty acids, and the systemic reactive oxygen species T, which decreases the nitric oxide into the endothelium, causing impairment and of course cardiovascular events. And also by eating food, restaurant food or pubs and drinking, and so high systolic blood pressure peak also has been associated by going out, creating endothelial dysfunction and hemodynamic protuberances, which may participate acute STEMIs. So brachial artery flow mediated dilatation has been shown to correlate with very early stages by high fatty meal, here having your hamburger from the McDonald's, that clearly that within hours with a high fat diet you have a decrease the brachial artery flow mediated dilatation, and also has shown that clearly that it is whether the control versus fast fatty meal, that you have this effect even in the recent literature. We have a study of 25 years ago corroborated again that eating fast fatty meal associated with decrease in brachial artery flow mediated dilatation. And this also goes down to that fast food intake. Once it goes beyond your one that you have per week, the intake of fast food is associated with higher incidence of cardiovascular mortality. Higher the fast food, higher is the mortality. Then second is the high salt meal. Similar phenomena is observed. High salt meal associated with decreased flow mediated dilatation. And very important, which is this experiment shows that once you have a high fat meal, you have decreased vasodilatation compared to low fat. But more important, if even you have a high fat meal but do exercise, not only it is attenuated, actually it's better. So you can eat. That's what we tell everyone. You can eat your bad food if you need to, but make sure you exercise, and that attenuates the bad effect of it. And this actually puts it together on the red, that various factors with the high fat meal working through reactive oxygen species and cause the endothelial dysfunction, decreased nitrous oxide production, and various cardiovascular manifestations. Therefore, chronic consumption of fast fatty meal can contribute to development of atherosclerosis and cardiovascular disease via decreased nitrous oxide bioavailability, manifesting as increased risk of cardiovascular disease, hypertension, and diabetes. So clearly that our change habit to everybody staying at home, not going to restaurant, is really helping in this factor. Clearly this is a good habit which we have developed during this COVID-19. So now the third factor is the relaxed lifestyle with improved physical and mental health, medical compliance, and reduced spurts of vigorous exertion. Home containment has resulted in less work-related stress and increase in indoor physical activities, has reduced trigger of plaque rupture. Working hours have become shorter, and one of the biggest irritant in our working lives, traffic, driving, and time to commute has significantly decreased. And of course, that shelter-in-place order, recreational leisure time indulgence in regular exercise, yoga, meditation, prayers might in part have contributed indirectly to the reduced incidence of cardiovascular triggers and promote heart healthy milieu. So also now, in the past, people were not doing regular exercise, they were doing a vigorous exercise, and we know vigorous sports of exercise can cause acute cardiac events. So all those have been nullified with this. Now we say, well, is there a relationship for the healthy lifestyle with the years lived without major chronic disease? 4 factors. Actually, this epidemiological study taking BMI, smoking, leisure time physical activity, and alcohol consumption. And they gave grade from 0, 1 and 2 could have a score of 0 or 8. So best number, if you have a good score, and that associated with the score could be from 0 to 8. that better the score gets you additional year of life. Higher the score, that means you are perfect in terms of the lifestyle scores associated with less disease in the future along mortality. And this was true for both men and women, gaining almost 7 to 8 years of their life. So it is important that patients are also more likely to be compliant with medication schedule at home, especially elderly patients getting extra family support and care. This practice will likely avoid blood pressure fluctuation, interval angina episode due to missed medication doses. And lastly in this, which really comes down to that huge convenience of newly adopted telemedicine and telehealth actually is helping in this matter, because avoiding time to travel to see the physician and use that extra time on individual leisure activities. So clearly is the downside of this. If of course continued, people are put out of job, they will be let go, salary decrease. This may really increase tension, mental stress in the future, but we need to see. So now lastly, the fourth point comes, underreported or patients dying at home. It is possible that some of these patients are not coming to the hospital, but having MI at home and dying. Actually, this has been shown that in the past, January, February used to be 20 deaths per day. But during this COVID time, that number has increased 10 times. Now, also problem here is that we don't know how many are due to COVID and how many are associated with cardiovascular disease, MI, and sudden cardiac death. We'll never know because nobody has autopsy. They are basically sent for burial. Another study in our New York area published in New York Times that COVID and heart disease patients are on top of what used to be in the past. So this is above normal. So many of these deaths, 6,000 deaths above normal from March 15 to May 2nd compared to similar time period year before. And many of these deaths are occurring at home and largely from coronary artery disease or maybe COVID. Nobody will know. But key is there's definitely more incidents of death at home. Also want to emphasize during this time, despite the COVID death, heart disease death is still higher than the COVID death. And what also negative phenomena is that the same paper from Italy showed that not only the STEMI has decreased, but more important, complication of STEMI and particularly fatality from STEMI from the similar time period of 2019 to now has really quadrupled. Why? Because patients are waiting longer before coming to the hospital and having a higher event rate of various complications as shown in this very elegant study, but 4 times mortality. So therefore it is unlikely but that this would account for 30 to 70% decline in cardiac related EMS call or MI presentation to emergency room and hospital. But in the face of this trend, we have urged the public to be cognizant of the telltale signs of heart attack and that they must seek urgent medical assistance if acute symptoms develop. We just had a ABC channel 7 news yesterday with Dr. Keeney. The patient delayed. He himself is a doctor and but came but was effectively taken care. So of course, during this time, we also learned the elective procedures can be put or postponed, but had to be very cautious, calling those patients every week that don't delay too much. And because late, once they delay their cardiac care, we know have a higher complication. So therefore, this is a nice pictorial from ACC, really emphasizing that even this COVID time, heart attack, stroke, call 911 and don't delay. And this I actually have put it together as a central figure of the COVID-19 containment on the top, COVID-19 infection, their pathogenesis, and acute cardiac in the events decrease, where we do not know that how much is because of underreported as shown here. So if I had to put this together, possible contribution of 4 factors, I really put the decrease in air pollution on the top because it was so dramatic and so quick. 50% contribution, 25% is our better food, 15% relaxation, and maybe 10 to 15% patients are dying at home and not or having MI at home. So just to conclude that we also learned that the power of non-pharmaceutical means in environmental behavior modification, which can play an important, significant role in reduction of cardiovascular illness. Therefore, we must encourage patients to recognize the symptoms of heart attack and acute coronary syndrome and seek urgent attention. And of course, avoiding acute care even during current COVID-19 pandemic is never a good choice. So future perspectives, basically that we learned quite a bit from this COVID-19 strategy. Do better for yourself, get your exercise routine, continues to follow, balanced diet, get hooked to Fitbit, calorie count, And of course, aggressive means to reduce air pollution should be implemented and be enforced by the national governmental agencies, because we learn by decreasing air pollution, we really improve the society health. This is the modification of the central figure of Raja Gopalan, which I put it together, that starting with your clean fuels, very important being that using natural gas, electric gas, and your electric cars, and of course the urban landscape reform, and at the personal level using various indoor and outdoor air purifiers, and do exercise and healthy diet.
Sharma, please conclude your slide, so we are really short of time.
Yes, I'm completing this last one. That future perspective basically is the aggressive compliance or risk factor modification, very important, and public policies to clearly report the calorie count is important. And of course, higher taxation on smoking and alcohol may further reduce their consumption. And with that note, I really thank everyone for listening, and all the organizers of APVIC giving this chance. Thank you very much.
Thank you very much, Dr. Sharma. Your talk has been very perspective. I think it's going to be giving a lot of thoughts to many people in India and all over, that we need to actually look at factors. Many of these are very pertinent. COVID is rising, and these factors actually play a lot of role. And most of us in India are actually, what I think is, they're missing out on MIs. They still don't. They are paranoid of coming to the hospital. Even I've seen doctors not coming to hospital because of risk of COVID infection. And I can tell in Delhi, every hospital now is a COVID hospital. So, and more than 50% of all hospitals are full of COVID patients. So this is very important. And I think this will be, food for our thought process and healthcare planners in both in Delhi as well as the central government. With this, I will just let me go to the question answer box, and if there is any question amongst the panelists, please, you can go ahead and ask Dr. Sharma.
Can you hear me?
Yes, Dr. Bansi, yes.
Yeah, thank you. Dr. Sharma, thanks for a wonderful summing up of this problem. Sweden is a less polluted country, and we didn't have any lockdowns. And yet we saw 20% less patients stemming for PCI. And I agree that even if pollution is less, but we still feel that the particles and so on, especially from exhaust from the cars, has gone down. So obviously there is something to it, as you put it.
Okay.
Dr. Sharma,
I know I went about 5 minutes extra, but but I'm glad that I was able to convey this. And this actually I gave a lecture on our CCC live, and it's on our review median. So has been a 5,000 download of this presentation, really put together various factors of this unusual phenomena which we noted.
Sure.
And what we see in India is that there's a lot of anxiety and paranoia about getting cardiac disease or even getting COVID, and that the thing is a death sentence. How do you think contributing to MIs at home? And because I see that's the biggest thing now in India. You have a COVID, there's so much of media publicity that it's a death sentence. So I'm sure that must be playing also as a major factor for acute MIs and at home and sudden cardiac death.
Absolutely. Okay.
Okay, thank you so much. Let me invite Ajay. Ajay, who's a very close friend and a very accomplished cardiologist, known all over the world for his research, for his interventional skills, and for his organizational skills. And he's going to be speaking about cardiac manifestations of COVID-19. And I know Ajay is a principal investigator for many trials, and also I think a trial which is looking at the doses of anticoagulants along with Sahil Parekh in managing these patients of cardiovascular manifestations with COVID. So Ajay, over to you.